My name is Samuel Cohen Tanugi. I'm one of the new PGY4s, and I will be talking today about geriatric distal radius fractures and how we should manage them. What should I click here? All right. So my only disclosure, I say this lightly, is that I love to operate. This is somewhat relevant because the punchline for my talk is that we're probably operating too much on geriatric distal radius fractures, and this can be hard to admit for a eager resident applying it to hand and wanting to do as many ORIFs of distal radii as possible. So let's jump right into the topic with an initial controversy about how we should even define the geriatric population or our population of interest. You know, it's easy to lump sort of every patient greater than 65 part of the Medicare database. Is that how we should define geriatric? There's obviously been a big shift in patient activity, and geriatric used to be thought of as similar to low demand. We kind of assume that older patients are not really up to much. Here's a picture of a 90-year-old man that I met in Japan who actually climbed down this ladder. He was trimming branches on his tree so I could take a picture of him. Clearly he's high demand and up to some risky activities. Here's a 74-year-old woman I met in the high Sierras on a 200-mile hike, and this was her 4th summer consecutively hiking this portion of the Pacific Crest Trail. You know, should we be considering physiologic age? We've all met 50-year-old patients with worse physiology than some 75-year-olds. And as I said, the elderly are getting increasingly active. Should we be looking at bone health as an important factor and maybe sort of the confounding factor relating to age? And finally, should we be discussing other aspects of health and patient care, such as the anesthetic risk profile with respect to cardiovascular pulmonary function? Is that what really matters in our decision making? So all this, you know, needless to say, I have to be cautious with what I say. I don't want to offend anybody. Recently on a trauma conference, I described a middle-aged man, somebody who was like 38, and I don't think my attendings appreciated that. So let's talk some brief epidemiologic numbers. So we all know as junior residents that these fractures are very common, and we all get very efficient at lining up our older patients in the emergency room with traps and local anesthetic so that we can reduce like 5 patients in the span of an hour. In the patient population Medicare greater than 65 years old, this is the second most common fracture. Hip is number 1. And just among Medicare patients, we have more than 85,000 patients per year who have distal radius fractures from low energy mechanisms, such as a fall on an outstretched hand. It's important to note that a fall from an outstretched hand, fall on an outstretched hand resulting in a distal radius fracture is diagnostic of osteoporosis because it's considered a fragility fracture. And I'll get back to this a little bit at the end. Women are more likely to have a distal radius fracture, and the incidence doubles every decade after 50 years of age. This probably has to do with that bone health and osteoporosis risk. Looking at cost, Medicare paid in 2007 $170 million in direct payments for distal radius fracture care. This doesn't include societal costs, purely what we do as physicians for our patients. And this has been expected to rise to up to $240 million if the current trends in operative fixation continue. So a little bit about the anatomy. There are numerous classifications for distal radii, and it's important to know these. I won't go into much detail here. You know, there's eponyms such as the Colle's fractures or Barton's fracture. There's classifications such as the Maloney, Frickman, Fernandez, or AO classification. I think for the purpose of operative fixation, you know, residents preparing for cases or anybody treating these intraoperatively, it's important to understand the 5 articular fragments in the column model that I've detailed here. Again, I'm not going to go too much into detail. This is especially relevant for higher energy mechanisms in patients with good bone when we're really trying to fix every small fragment. And here's a picture of a geriatric patient, 70-year-old with a Colle's fracture that we saw in the emergency department. The Colle's fracture, which is dorsal displacement, obviously when you're falling on your outstretched hand, is very common in this population. And with poor bone health, you often have comminution. Also, a Barton's fracture, a volar displacement fracture, is common if you fall sort of on the other side of your hand. So here you see dorsal angulation, no evidence of intra-articular fracture. And I'll come back to this patient, you know, in terms of her treatment throughout the talk. So what is the current paradigm for how we manage these? The goal, as usual, as physicians taking care of these patients, is to restore a functional limb and painlessness. And the overarching theme here for the current paradigm that we find ourselves in is that we think we have to restore the pre-injury osteology, and that we want to preserve the articular surface. That's sort of, a big theme in orthopedics and what we do. So where does this paradigm come from? And I'm going to show you that, there's really a few classic historical articles that have shaped and influenced how we think about managing these to this day. And I've selected 3 classic articles. I didn't select them for how good their scientific methodology was, but mainly because they are the most cited articles on this topic and because they really paved how we think about these injuries. The first is a classic article. This is the most cited article on distal radius fractures by Gartland and Worley and JBJS in 1951. They looked at 60 Colles fractures with an average age of 53, and they performed physical exam on these patients and obtained x-rays. And their biggest contribution is the normal osseous parameters. This is where those numbers come from that all of our sub-Is are memorizing and that we learn as interns when we're looking at distal radius fractures. Volar tilt of 11 degrees, radial height of 11 millimeters, and radial inclination of 22 degrees. They really defined that that's what a normal distal radius should look like. And then they further argued that displacement from normal decreases the range of motion after, sort of a malunion, and that intra-articular displacement increased the risk of radiographic arthritis. And finally, that a high rate of displacement was noted after plaster immobilization. The next article by Knirk and Jupiter in 1986 was a retrospective review of 43 patients. They were younger, less than 40 years of age. But this article really also set the tone for the importance of treating these. So they argued that there's a critical importance of restoring the articular congruence in order to prevent arthritis, because they correlated that with post-traumatic arthritis. And this really set the paradigm for treating distal radius fractures. Finally, a little bit less cited, but the article by Lafontaine in 1989, all of the residents are frequently asked about Lafontaine criteria. I think sub-Is are probably memorizing Lafontaine criteria as well. I was asked about Lafontaine criteria just last week in clinic. And so they evaluated what factors lead to unstable distal radius fractures. So, the risk of redisplacement after initial reduction. And they found five factors: dorsal angulation, dorsal comminution, an intra-articular fracture, an associated ulnar fracture, and age greater than 60. And they argued that if you have 3 or more of these, you're at very high risk of redisplacement or of having an unstable fracture. Okay, so with that paradigm in mind, that which fractures are unstable and the risk of having a malreduced or incongruent joint and the importance of treating those, even though all of that literature was in young patients, and some of the authors of those early articles have since written articles about how poorly designed those studies were. What are our treatment options? So number 1 is non-operative immobilization. Some of the advantages here are that it's not invasive, obviously. It's relatively cheap. You don't even need a surgeon. Ideally, this could be performed well by an emergency room provider, and then the patient could actually follow up, not even in a surgeon's clinic. We've started having our sports non-op clinic here that could follow these. And the standard of care is initially for a splint, followed by a cast with weekly x-rays. Some of our attendants have started placing these directly in short arm casts so that you avoid the loss of elbow range of motion, and then you don't also need to transition from a splint to a cast in the office before the fracture is fully healed, and you risk redisplacement at that point. Some of the complications cited most commonly are a high risk of loss of reduction or malunion between 50 to 100%, depending on what you read, as well as median nerve symptoms, but rarely requiring surgery. Now, with a complication rate of 100%, it's, might be better to describe that as a expected outcome rather than a complication. So that patient that I showed x-rays for earlier was closed reduced in the ED. I'll be a little bit critical of these since I performed the reduction. I think I didn't quite restore the radial height as well as I could have. And you can see the hand is actually a little bit in radial deviation there. So a pro tip for our juniors and interns, pulling on the thumb at the time of the reduction can also help realign that radial height. But otherwise, I think it's looking pretty good in terms of volar angulation there. Next option surgically is an external fixator. So again, some advantages. It's minimally invasive, although there's a higher rate of injuries noted, such as damage to arteries, nerves, or even fractures of the radius at the site of the pin, perhaps if you're, putting more than one hole. The biggest limitation of an X-fix really is how bulky it is and how it interferes with the patient's normal daily activities. In older patients, an X-fix can be a little bit heavy and certainly very inconvenient in terms of personal hygiene, or if your patient is, taking care of somebody else, for instance. You also require pin site care, and they might need one of their family members to perform that pin site care, since one of their extremities is not useful here. And there's a high rate of pin site infection. And finally, X-fixes, we don't necessarily know this as residents, but they're quite expensive, surprisingly so. Next up is closed reduction with percutaneous spinning. We're more familiar with this in our pediatric patient population, but this is studied in all age groups. Again, advantages, it's not invasive, and it's relatively cheaper, but it still does require pin site care and a similar pin site infection rate to external fixator. Lastly, internal fixation. I'll briefly talk about various options, but I'm going to go a little bit quicker here because this is not a surgical skills talk. I'll mostly focus on volar lock plating because that is sort of where the money's at. It certainly accounts for the greatest increase in cost that we're seeing, and it's definitely the most commonly used. But there's also dorsal plating, bridge plating, and fragment-specific fixation. So volar lock plating has seen an exponential increase in use since the 2000s. It's certainly the most common fixation strategy used, and it's also quite expensive. And as I said, it accounts for the majority of cost increase in those estimations of where we might be headed in terms of our Medicare expenditure. One of the downsides is through a volar approach, you can't actually look at the articular surface. Complications include flexor tendon irritation or rupture, such as the FPL, due to the plate position. And this is a common reason for hardware removal. You can also get extensor tendon irritation if your screws are proud, although the locking technology, especially for osteoporotic bone, makes it easier to not have bicortical screw fixation, and so decreases that risk. The dorsal lock plating is an option. This was originally not that favored because the implants were a little bit bulkier, high rate of extensor tendon irritation and need for plate removal, but some of the newer plate designs are locking and lower profile, so this might change. An advantage of the dorsal approach is that you can get that dorsal, that articular exposure through a dorsal capsulotomy. I won't talk about fragment-specific fixation. It's really mostly used in in higher energy mechanisms in younger patients. Finally, bridge plate, although I haven't, none of the randomized control trials that I'm going to discuss shortly here talk about bridge plate. I think this is actually a great option. It's sort of somewhere in between. It's essentially an internal X-fix. It's obviously lower profile than an X-fix and allows the patient to be more autonomous early on, but it's less morbid than an ORIF because you're not actually doing a reduction necessarily and trying to fix fragments. And it bypasses the poor metaphyseal bone stock that some of our patients have. Complications, it's not really a complication, but obviously you need to do a second surgery to remove it. And then you always have a risk of extensor tendon irritation or rupture, and you might not necessarily be capturing some of those volar fragments that are critical for radiocarpal stability. So with those treatment options in mind, our job is to counsel patients, especially in the age and the era of shared decision-making. We want what's best with our patients, but what do we actually know about what their values are? So in a study, in a qualitative study of one of the larger randomized control trials that I'm going to discuss shortly, there was a sort of a side article published where the patients were interviewed. Some of the patients were interviewed for a qualitative study about what were their values. So number one was function. Patients care about returning as much as possible to their pre-injury function. When patients discussed painlessness, it was interesting. They actually sort of assumed that whatever options we're presenting to them will do a good job of reducing pain. So, that's not the case. It certainly should be discussed because patients tend to assume that we're not going to offer them an option that's going to be painful or not control their pain well. Next was autonomy, and this might be surprising to us. Most of us, treating these patients are going to be a lot younger and don't necessarily realize the importance of autonomy. when you're older. Some of these patients are living at home alone. Some of them are taking care of their spouse. Some of them are on babysitting duty. And even during that convalescence period, those initial 2 months of care, if you're not able to not only take care of your own pin sites, but take care of your own personal hygiene, that's kind of a big deal. Patients really cared about avoiding complications. Oftentimes, if you read our notes or witness our conversations when we're consenting patients, we're very quick. There's a risk of damage to arteries, nerves, and vessels, and infection and wound complications. And we say that sentence in about 5 seconds and move on. But some patients really care about avoiding a particular complication. It might be because one of their family members or friends had a complication, and that's just what's on their mind, or they might have a different risk profile. And so, since some of these treatments have very different complication profiles, it's important to talk about, some patients just really want to avoid anesthesia. Some patients are really worried about infection and want to avoid a pin site infection. And then finally, aesthetics. We tend to think that aesthetics is going to be really important, but in this particular study, and this doesn't mean that it's the be all end all, but patients most oftenly talked about aesthetics, meaning the deformity of their wrist, to say that it was not as important as the other values, but still something worth talking about, obviously. In terms of other factors that we might not always talk about, but there are certainly surgeon factors. There was a study showing that surgeons who are part of the Hand Society are almost 3 times more likely to use internal fixation on any given fracture. There's also regional or even sort of zip code or socioeconomic background differences in who gets internal fixation. There's also the perception of outcome, or essentially wanting to get great x-rays or a treatment that feels like it's the best outcome for the surgeon without necessarily thinking about the functional results for the patient. And then finally, a topic we don't often like to bring up is conflicts of interest. And obviously our field is intimately tied with the industry, and it's important to talk about that as well. So we want to counsel our patients appropriately and come up with shared decision-making, but what can we confidently say from an evidence-based standpoint about these injuries and how we should manage them? So in this next section, I'm going to dive a little bit into the literature, but what I'm going to do is I'm going to focus on a few key questions that we ask ourselves and that our patients more commonly ask us. And I'll look at the studies sort of in light of those questions. So I'll start by presenting the studies, but I won't go into the results until we start talking about the questions. So question number 1, which fractures are even unstable? And so we're back to those LaFontaine criteria that we're always pimped about. So here is a systematic review in 2016 on the left side, which looked at, again, some of those same criteria. And they found that really age greater than 60 was your biggest predictor. They also noted female sex and dorsal comminution may be factors as well, but the other two, intra-articular fracture and ulnar fractures, made no difference to the instability of the fracture. And then another study 1 year prior in 2015 showed that age again was a predictor of secondary displacement, as well as initial displacement on the injury films predicted a secondary displacement. But they found that dorsal comminution was not associated with risk of displacement. So we're not entirely sure, what those factors are, but it certainly looks like those LaFontaine criteria are not as evidence-based as we thought. And age is definitely our biggest factor. So other questions that are going to be important: do casts actually maintain reductions? And if not, are malunion and arthritis a problem? Next, is surgery better than non-op? And if you are going to take a patient to operating room, which surgical fixation is best? So here is fresh off the press from last month, our largest RCT looking at geriatric distal radius fractures, 24 international sites, including our own Ortho Carolina. They looked at 304 adults greater than 60 years of age who were independent, meaning patients actually had to be able to come to clinic alone, weren't living in a skilled nursing facility, weren't generally particularly low demand. And these distal radius fractures needed to meet surgical indication, meaning they were deemed unstable, but they needed to be able to be fixed by any of the 3 options: ORIF, XFix, or CRPP. The patients who were treated non-operatively were self-selected, so this was more of like an observational side cohort. It's interesting to note that 60% of eligible patients declined to be in the study, so a little bit of a self-selected group. And then we now have 24 months follow-up. Their primary outcome was the Michigan Hand score, so the patient-reported outcome score. Secondary outcome included pain, grip strength, and complications, as well as 3-month outcomes. The next randomized control, the second randomized control trial earlier this year, out of Australia and New Zealand, looked at 300 patients. 166 of them were willing to be randomized to either volar lock plating or cast, and the 134 who declined for randomization were observational. So they got to choose whether they got XFix or IF or a cast, and they were observed. And we have 12-month follow-up for them. This study, is important to note, excluded volar angulated fracture. So they were really looking at the dorsal angulated ones. Their outcomes were patient-reported outcomes at 12 months, and then secondary outcomes, DASH, pain, and 3-month outcomes, as well as complications. Skip over this one. And then last that I'll discuss here, a systematic review. Unfortunately, or interestingly, this was published the year prior to those other 2 big RCTs, which are the largest RCTs. So they don't include our best randomized control trials. So I hope that they come up with a new systematic review after this. But they looked at volar lock plating with 253 patients versus non-op casting in 274. They looked at DASH at 12 months, and then secondary outcome was 3-month scores, range of motion, radiographic alignment, and complications. So question number 1, does a cast actually maintain a reduction? And the answer is no. Depending on what you look at in the literature, you have anywhere from 50 or so percent to 100% of malunion, and 77% with a visible clinical deformity when you actually just look at the patient's wrist. And as I said earlier, if you have rates of malunion that high, it's really difficult for me to look at that and say that's a complication. That's really just what you expect with this treatment. And I think patients should be told that accordingly. However, with malunion and arthritis, is that a problem? And the answer pretty clearly seems to be no in these studies. Patients with osteoarthritis did not report more pain at 1 year, and there's really no correlation between the functional results of our patients and the radiographic results in non-operative distal radius fractures at greater than 60 years of age. Is surgery better than non-operative treatment? Well, it depends on what your goals are. If you're trying to restore the osteology, clearly yes. You have, as I said, high rates of malunion and clinical deformities in the non-operative group versus if you're actually restoring the bone, the osteology, and fixing the bone, then you are probably going to get much better outcomes. But at restoring function, range of motion, and decreasing pain, long-term, there's really no difference at 12 and now 24 months in patient-reported outcomes, range of motion, or pain. What about restoring function, range of motion, or grip strength quicker? It looks like using volar lock plating, because I can't comment on the others since they weren't the other fixation strategies. It looks like volar lock plating does make a difference in the early time points. Here's a graph in the wrist trial, the largest one that Ortho Carolina was also a part of. And you can see that all of the outcomes sort of even out or end up close together at the end. But early on in the first 2-3 months, which is when you'd be immobilized in your cast anyways, there really is a difference in scores. So if you are going to take a patient to operating room, is there one surgical fixation strategy that's best? It seems like long-term, they're all equivalent, and they're equivalent to non-op as well. This even seems to be true for pinning in younger patients. The draft trial, which I didn't go into here because it's looking at younger patients, has 5-year follow-ups now. And although there's criticism of the study and things we can argue about in terms of what to conclude from it, they find that percutaneous, that K-wire pinning is equivalent to volar lock plating long-term. But for early function, it really seems like volar lock plating is best at 6 weeks and 3-month scores. So in terms of complications, as I said, different profiles. XFix was the only method that had a higher rate of overall moderate complication. But again, the complications are just different. So volar lock plating had a higher rate of tendon injuries, and XFix or CRPP had a higher rate of pin site infections. Some of the limitations in looking at this data are that you really have to look at the exclusion and inclusion criteria when you're applying these large trials to the patient sitting in front of you in the office. If you look at their exclusion criteria, surgeons are excluding a large number of fractures based on some of the questions that we're trying to answer in the first place. So when a surgeon says the fractures must be amenable to all 3 methods of fixation, that's the question we're trying to answer: are all three methods of fixation equivalent? So as well in the draft trial, which I didn't discuss. There's a statement saying patients were excluded if the surgeon thought that the surface of the wrist was so badly displaced that it required open reduction. Well, which are those that require open reduction? And then some of the studies are excluding certain fracture patterns. So one of those large randomized control trials doesn't speak about volar angulation. Does any of this hold true for volar angulated fractures? And then some people argue that 1 to 2 year follow-up is not enough for some of those post-traumatic arthritis type symptoms or ulnar-sided wrist pain after a distal radius fracture. So 2-month follow-up for that patient I showed x-rays of. Clearly, she has a clinical deformity. You can see it's kind of like that club hand look where the ulnar head is prominent. She lost a little radial height and she lost a little bit of not only just radial inclination, but radial height as well. But she apparently was doing well at 2 months and never followed up after that. Some conclusions and take-home points for our talk. Number one, our geriatric population is not well defined. This is something we're sort of scratching our heads about, and we will continue having conversations about who is geriatric and what that really means. Number two, a low energy distal radius fracture is a fragility fracture, diagnostic of osteoporosis, and should be referred accordingly in terms of bone health care. And I'll talk a little bit about our bone health clinic at the end of this. Distal radius fractures represent a vast spectrum of injury. You have to check the exclusion criteria if you're using some of these studies to come up with decision treatments for your patients. It's still unclear what the indications are for open reduction. If your patient has malunion or arthritis, I would not consider this a treatment failure in non-operative management. I think this is expected and you should not worry about it in terms of functional outcomes. There's a large subset of unstable fractures that can be managed successfully with casting and appropriate counseling as to what to expect, including that deformity. Shared decision-making, risk profiles, and resources should determine treatment. Obviously, Volar lock plating is more expensive. But the cost of the Volar lock plating system should not be a fixed variable in an ideal market, So reducing cost of implant is something we can always talk about. And then shifting surgery to the outpatient surgery centers, as we're seeing, could shift the equation about the cost. Most of our outpatient surgery centers now have a fixed case cost of less than $1,000. So, it doesn't matter how many locking screws you're using. It doesn't matter if you try one plate and then switch to another plate because it wasn't the right size. They charge about $900 for the case. And so if we continue to change these costs, then, it may be that it's not that much cheaper than coming back to clinic 4 weeks in a row and getting x-rays. So those are my take-home points. Lastly, a plug for bone health. Under the supervision of Dr. Karenacker, our own JC Holzinger now has a bone health clinic. She's kind of retired from the Myers Park clinics in order to run this. And here are the appropriate numbers to call or make a referral. Any patient who has a fragility fracture really should be referred to this clinic. And this could be done, or maybe should be done, by the junior C in the console. I mean, there's no reason to delay it. It's only a higher risk of falling through the cracks. And, we have an opportunity here. The outcomes are probably going to be fine, whether they're treated or not for their fracture. But if we can prevent a hip fracture down the line, or vertebral compression fracture, or, change their mortality, that's actually significant. So I'll take any questions or comments. Sorry for going a little bit over today. And I want to thank Dr. Gaston, Dr. Chatterton, Dr. Garrett, Dr. Shu, and Dr. Karenacker in particular for help in preparing this talk.
Thanks, Samuel.
Thank you.
So I'm trying something a little new that we thought of is to maybe use a phone logged into the Zoom so people could hear the questions. So we'll kind of use this as a microphone, assuming that people can actually hear this who are online. Thanks for plugging the Bone Health Clinic. I think that's a great point. I was actually getting ready to say that as my first comment. So it was nice to have the links up there. But you're exactly right. Finding somebody and identifying somebody who's at risk of fall with a distal radius fracture could truly save them from a more life-threatening hip fracture. So it's a really, really excellent point you're making. I know that a lot of our hand team is watching online. So I'd open up to see if any of them have any comments or questions.
Samuel, this is Larry Kempton. I just wanted to say that in your discussion of non-operative management of distal radius fractures, I think I'd be careful about saying that you don't need a surgeon to treat them. I think you probably don't need a surgeon to follow them, but in terms of deciding on non-operative management, I think ideally you would always have a surgeon have that discussion with the patient, because surgeons are the ones who can more in detail discuss risks and benefits of surgical and non-surgical treatment. And having someone who's not a surgeon have that discussion with the patient could potentially bias the conversation, or even just give the patient inadequate information to make a decision.
Samuel, great job. Thanks for the plug for JC. And one question I have for you, and this is the challenge is, as you said, we're surgeons, we like to operate, and you showed the data that shows that there's really any difference. How do we actually have equipoise in having this discussion with the patient? So how are you going to balance your desire as a PGY4 wanting to operate with the data that you just presented to us?
That's a great question. You know, as a doctor, I think the message really needs to be that these patients will do well, you know, depending on what their goals are with non-operative management. I really think that needs to be the message. As long as they're, you know, we feel that their fracture is amenable to that. I still think a lot of patients are choosing surgery despite that. You know, if you look at some of those, the high rate of patients who don't want to be part of these studies, the most often cited reason for that is that they just wanted to go ahead with surgery and didn't want to be randomized and have a risk of randomization to the non-op group. So I'm not too worried about my case log numbers, but you know, really the takeaway for me is we need to emphasize that with appropriate rehabilitation, appropriate expectations, and sort of that grit or resilience piece, patients will do just fine without surgery.
Dr. Gaston, you have a question?
Yeah, good talk, Samuel. I was going to add one thing that was really been helpful for me that Dr. Ozier kind of taught me, which is one of the things, and we certainly don't treat distal radius fractures for the purpose of cosmetics. But I do think one thing that's important in this age group is at around the 1 to 2 week mark, if you're going to treat them non-operatively, take down the splinter cast and let them see what their wrist looks like, because you know they do have this appearance of sort of like a traumatic radial club hand look. And I tell them exactly what you said. I tell them that the data would suggest that at a year they're going to be doing just as well whether or not they have surgery, but that this is what your wrist is going to look like. And I will tell you, there is a subset of people who are extremely dissatisfied with that appearance, and at least in their eyes, it's truly unacceptable to them. And they also then usually say, and I would like to get back sooner and not be in a cast for the next 6 weeks. But I think it's important during the treatment to let them see what it looks like, because otherwise, if you just have it in a splinter or cast and you take it off and unwrap the present at week 6 and show it to them, there's going to be a subset of patients that are very dissatisfied.
Great. Well, thank you for logging in from vacation to support Cohen Tanugi today. We have run a few minutes over, but thank you, Samuel, for a great talk. Good discussion from everyone, and we'll look forward to seeing everybody next week.